So, dear colleagues, thank you once again for inviting me with my presentation and for choosing this topic among lists I've sent before. It's also necessary sometimes to refresh your own opinion about this topic with isolated sphenoid sinusitis. I would like to speak this 15 or a little bit more minutes about possible complications and how to exclude it. First of all, solution of this problem laying on the field of patient selection, of course. Clear examination of integrity of sphenoid sinus bony walls, it's a secret and key number one to prevent any complications. Why I am speaking about possible complication? Because luckily I had never major complications than operated sphenoid sinus in inflamed sphenoid sinus. I mean cases then sinus is not involved into tumor pathology. It's only inflammation and only isolated situation. Then we don't need to remove, for example, middle turbinate or to sacrifice nasal septum. How to open it? Much more easier, fast, and without any risks. So, of course, as usual, I would like to present a number of my cases. This is not a common pathology, as you see, among 2,000 of my first patients during about 2 years, there was only 19 isolated sphenoid sinusitis. It was all chronic situations, and among them only 4 common types of pathology was found during surgical procedure. It's not working. Yeah, I know. Only maybe, no. Pointer also don't work. It's a comparable number of patients with fungus ball, polyps, cysts, and mucosal non-fluent. And except this number, we have several extremely rare observations of foreign body. That was tooth in sphenoid sinus and osteoma of sphenoid sinus, which leads sometimes to inflammation and block sphenoid sinus. What is the main for sphenoid sinus surgery without removal and neurosurgical procedures with removal of septum and removal of middle turbinate? To find osteum, and in isolated cases, it's better to open sphenoid sinus directly with usage of 3-dimensional CT. This is the main point of examination. Now we have possibility to examine 100% of our patients exactly in our clinic with cone beam computed tomography. That's why we can examine all these bony walls and how it's related with carotid artery. If bony walls is complete, no destruction, we can operate. And for this surgery, main problem is bleeding. And you see here area of septal branches of sphenoid sphenopalatine artery, once again. This is nice observation, is normal blood pressure, but it's pulsing. We know well where is it branches localized in cadaveric patients, but here it looks dangerous and it can fear beginners if it starts bleeding. But now we know exactly that area of our surgical intervention up from this level of pulsation. Bleeding in this area is not strong and not severe. From septal branch, it's also not so dangerous. You can cauterize, but we have to know this example. Of course, many hospitals, university hospitals, 100% has possibility to operate together with neurosurgeon or have as for extraordinary situation with complication, we can invite to call neurosurgeon. But many hospitals, federal clinic has no any neurosurgeons. It's difficult to call neurosurgeon, and we need to solve this problem, or it's better to prevent. I think in 100% cases we can prevent major complications as internal carotid artery bleeding. Here I present in right side sphenoid sinusitis, but I'm not sure about bony wall surrounding carotid artery. So this patient needs additional examination, for example, MRI. Sometimes if it's carotid artery aneurysm, we use, of course, endovascular stenting, and this is clips not inside sphenoid sinus, but it was interpreted by some X-ray examinators or some ENT specialists as sphenoid sinus foreign body. Of course, it's not foreign body. When we use films or screenshots, it's old-fashioned procedure. We need only three-dimensional. Here you see arrow on the level of internal carotid artery looks nice, but it's not sphenoid sinusitis. It's a situation with some tumor, chordoma, for example, and then you examine step by step. You see here effect of bony wall. No, it's not working. No mouse. Sorry. So this patient also out of our group for exact rhinological intervention without neurosurgeon. This patient needs additional, more comprehensive examination. And this is method which we use also without image guidance. I use image guidance very rare in sphenoid sinus surgery. Usually it's enough to understand these three-dimensional relations between all bony walls and risky hazardous structures. This is MRI of patient with Sternberg canal from collection of Andrei Lopatin. He presented it me for this lecture. This patient, when we magnify computer tomography, also out of our group for rhinosurgical intervention. Of course, it looks like tumor, sphenoid sinus tumor or something like that. Another problem is anodic cells. In isolated sphenoid sinus, it's easy to make a mistake. Then you open completely ethmoid cells and sphenoid sinus, you are sure you opened everything. But if you open only one cell, you can be wrong. This upper cell is anodic cell, and it's very common. We find it in about 30% cases of our patients that this is luckily normally pneumatized sinus. Very interesting anatomy. It looks like on screenshot like two levels sphenoid sinus. In the upper part you see anodic cells with optic nerves going through. If this patient gets sinusitis, it's really risky and we have to be careful. Then we open sinuses in such cases. We usually open it via ethmoid, and I will show you all types and all approaches to sphenoid sinus: transeptal, direct, or via ethmoid cells. Each of these methods has indications. Sometimes situations looks simple, like here, but we need curved instruments or wide opening to reach this pathological process. This is fungus ball, and it leads sometimes, not sometimes, 90% cases to headaches. In compare with maxillary sinus, it's much more and much more common symptomatic sinusitis. Now, then we find cyst in maxillary sinus. It's usually not the cause of headache. With sphenoid sinus, situation is completely different. One more, I show you again Sternberg canal. After exact examination, it needs absolutely other intervention. Only opening of sphenoid sinus is not enough. In isolated sphenoid sinus, usually opening is more than enough. And removal, of course, of fungus ball or cyst, for example. Sometimes fluid level in sphenoid or other sinuses, it's not fluid, inflammative fluid. Sometimes it's CSF leak. In this case, I remember 15 years old video, patient of Professor Pluzhnikov, you remember most of you remember him well. And this patient later on was operated by Heinz Stamberger. Very uncommon case, spontaneous CSF leak from sealing of sphenoid sinus, spontaneous in young men, very uncommon. And now about approaches. In isolated sphenoid sinusitis, it's a highly important thing, what you opened. You see some pathology on computer tomography, and now you see here sphenoid sinus is clear. Of course, for me, situation is better. I know computer tomography and I know the story, but there is pathology. It's a little bit up and to the right. It's left nasal cavity, and you see here pus. It's anodid cell. It's isolated anodid left anodid cell mucocili. Also uncommon, but symptomatic. And it's easy to make a mistake, to open sphenoid, but not to open anodid cell. And I think it's not a good idea to open all ethmoids with normal pneumatization to reach this posterior anodid cell. I use direct approach also in such a situation, but it's not very common. Another very interesting case, opacification of left sphenoid sinus, and as usually we found ostium in almost typical place, but it's dry, and you see here floor right beneath from this ostium and low level of this ostium. I'm trying to find sinus, but it's not easy. And this patient underwent unsuccessful opening in very strong rhinological clinic. It was not successful. They also didn't use drill, and they couldn't open sphenoid sinus. This false ostium may be a result of previous surgery, non-successful, but there was also marks of previous instruments, some points there surgeon tried to penetrate. He was not successful, and now we found this new artificial ostium. You see sinus is full of pus. I think this ostium is also anodid cell, which was drained artificially with new self-made ostium, and this is sphenoid sinus. That means sometimes natural ostium, it's not exact point for orientation. Sometimes you can be wrong. Again, about relations between anodid cell and sphenoid sinus. That was case of total polyposis. Left side is opened completely, and all sinuses was filled with the polyps, but only sphenoid sinus filled with mucin or pus. That's why I recommend always in patients with severe destructive polyposis to open sphenoid sinus, but only in cases if all integrity of bony walls is complete. If you also can use shaver inside sphenoid sinus if you are sure about bony walls in three-dimensional. For isolated sphenoid sinus, a common recommendation to open it directly. But how to open directly in case of such a conhabulosa and septal deviation? It's difficult to reach natural ostium and anterior wall. In such cases, I prefer transseptal approach also to correct nasal septum and to improve nasal breathing. Septal surgery for frontal sinus is very common, for sphenoid not so, but now I oftenly operate sphenoid sinus via septum, mostly in cases of severe deviation. I operate septum totally with endoscope from first cut. From hair removal, I start with the endoscope, then continue to the end. And sometimes it's much easier to open sphenoid sinus. Bony walls in area of natural ostium can be thick. In area of rostrum, it's usually very thin. And you see here, we are already inside sphenoid sinus, without bleeding, with nice correction of nasal septum. And we found this cyst, and on the right side some mucin. This is isolated sphenoid sinusitis with headache and many symptoms. Usually surgery of sphenoid sinus gives good clinical results if we are correct in patient selection. We know what we do. And the MRI indicated, of course, not in 100% cases. One I want to skip. Now, fungus ball. Totally, we operate in our clinic about 60, 70 patients with fungus ball of maxillary sinus. Sphenoid sinus fungus ball is less common. Fungi is usually we found in patients with chronic polyposis, but this is isolated fungus ball. This is wrong surgery. I now don't use any forceps. I make an irrigation and flush. It removes immediately. Then we need complete endoscopical examination. Now cyst. This pathology often leads to headaches, and if in cases of maxillary sinus cysts, it's a really accidental finding after examination in neurological department. But here you see strong cyst with a thick capsule, and it's laying on the floor of sphenoid sinus. Looks simple, but it's very symptomatic usually. Now we gently examine with a forceps where it fixed, what is content. So it was really rigid and pressing to the lateral walls of sphenoid sinus. Of course, sphenoid sinus isolated cyst, much more indicative for surgery than maxillary sinus cysts. I usually, if patient symptomatic, operate the sinuses. Of course, gentle, without removal of middle turbinate and without removal of posterior nasal septum. Removal of this capsule is very indicated. You can compare our modern scopes. Previous videos was our old story. And then we compare size of this cyst. We removed everything or not. We are measuring with a fluid size and capacity of sphenoid sinus and compare it with results of measurement after three-dimensional CT. It's nice, very handle method which can be used. Now we can know what is the capacity of sinus, and we removed everything or not. Now it's time finishing already. I want to show you only a couple of cases. Sometimes small cyst is indicated. Here you see on the cross small cyst. I was ordered by strong ophthalmological professor to operate them because this patient loses his vision. And we found this cyst, we removed it, and we stopped this progressive vision loss. Sometimes in sphenoid sinus, also small cysts should be removed. Now, this is a rare case of osteoma. Let me skip. And this case with sphenoid sinusitis opacification and uncommon symptoms. It was posterior nasal bleedings, repeated posterior nasal bleedings. And this is endoscopy under local anesthesia. You will be surprised. All previous cases was operated under general, of course, with laryngeal mask mostly. Here we examining nasal cavity under local anesthesia. And we found this foreign body in sphenoid sinus, it's tooth. Young woman after severe criminal trauma of mid-face. Tooth was inside sphenoid sinus, and that was uncommon cause of sphenoid sinus inflammation with repeated bleedings. So, and finally, about sequel of sphenoid sinusitis. Sometimes it can be normally pneumatized after surgery. Sometimes it can spontaneously obliterate. That was a young lady after my surgery. after very gentle removal of left sphenoid sinus cyst. It's completely closed, but this situation looks like osteitis, but non-symptomatic, no symptoms. Her preoperative symptom was headache. Thank you so much, and finally, a couple of information about our World Congress. You can find here in our audience some flyers with information, but without dates. This is exact dates of our Congress in 2021. This is middle of July, middle of summer, and of course you will prefer it. Don't visit St. Petersburg in winter time. It's terrible. You are very welcome. Thank you for your attention.